Hello, everybody. It's fantastic to have you here on the final webinar of the series that Digital Health London, UCL, MedCity and HIN have been organising, exploring digital health in a variety of ways. And today's webinar is all about regulation and evaluation of AI. Are we there yet? And I am Neelam Patel, Chief Executive of MedCity. I am joined today also by Professor Henry Potts, co-chairing. Henry has also been co-chairing previous webinars, and there's a nice double act that we will be following today. I'm really excited actually to have with us today on our panel Jeanette and Liz, Jeanette from NICE and Liz from the Health Research Authority. And the really important thing about this webinar and why I'm so excited to have them on board is both of them are at the crux of where some of these regulation evolution and changes are happening, particularly with respects to digital and AI and data-enabled technologies. So I hope that they will be able to answer our question, regulation and evaluation of AI, are we there yet? So before we just start off on the conversation, just a few housekeeping rules. Firstly, please do use chat for your questions, comments, and I will be asking you a couple of specific questions before we start the discussion. Once we've had the panel discussion with Jeanette and Liz, Henry will be looking at your comments and questions on chat, and we will be reflecting those back to the panel and engaging in a bit of interactive discussion. So please do use the facility. So before I ask Jeanette and Liz to introduce themselves, I just wanted to reflect back a little bit on the evolution of particularly the NICE evidence standards framework, which MedCity and DHL were, very closely involved in. And, for me personally, it was a fantastic opportunity to engage with industry, particularly to co-design a framework that really told the industry, as well as internationally, what good could and should look like for digital health technologies that were being developed for the UK health and care system. And what I think we have now is an evolving landscape. So these frameworks were developed in 2018, and a lot has happened since then. A lot has happened from an experiential point of view, where innovators were actually using the framework, as well as technology sort of evolution. And more AI now being developed and adoption being looked at. So I think this topic today is very useful then to see how the framework is evolving to match that. And also really important to have the Health Research Authority being represented here as well, particularly with respects to data and the role that the HRA plays in guiding innovators in use of data and in evaluating, therefore, their technologies moving forward. So with that, and before I ask Jeanette and Liz to introduce themselves, I'd just like to ask the participants on our call here to put down on chat the answers to a couple of questions, if I may. One is, could you indicate in chat if you have used the NICE evidence standards framework in some way or form, is one question. And second is, could you indicate if you have already had experience in working with the HRA or NICE in terms of technology evaluation and development. So those questions would be just fascinating to know about, and might help Jeanette and Liz also talk to the relevant audience. So can I just kick off then, and firstly ask Jeanette to introduce herself and what you do at NICE, and then Liz, the same to you.
Thanks ever so much, Neelam, and thanks for having me. Really exciting to be here. I love talking about this topic, so I'll try not to waffle on too much about it. So hi everybody, I'm Jeanette Cusel. I'm the director for the scientific advice team at NICE. For those who are not familiar with NICE, we are the ones that evaluate the effectiveness and cost effectiveness of medical technologies for the NHS. And this now includes digital health technologies, including AI. So it's exciting times. My team at NICE is the scientific advice team. We work with the life sciences industry early on in the development of their products, supporting them to understand how they need to evidence their value propositions, what evidence they need to generate, where their gaps in their evidence are, and how they can generate economic data as well as the clinical effectiveness data. And we have been working more in the last few years with AI developers, and particularly through the AI award, which I'll talk about a little bit later. I'm also the NICE lead for the multi-agency advice service for AI, which is a initiative in development that Liz and I will both speak about later because we work closely together on that. Thanks.
Fantastic. I'm also really excited to be here. I'm the head of data and AI policy at the Health Research Authority. For those of you who haven't come across the Health Research Authority before, we are an NHS arm's length body, and our role is to make sure that all research that happens in health and care has the right legal and ethical approvals, and we also ensure that if you are applying for data that is confidential, identifiable patient information, that you have the right legal framework to do that under, so we can provide a legal permission to access that data. So we have some quite interesting roles around ensuring that the data is used in a trustworthy way and making sure that patients and public are involved in those discussions. So I'm really excited to be here, and we've been developing our portfolio around AI and data-driven technologies, and we'll talk a bit more about that as we go through this chat today.
Thanks, Jeanette and Liz. So just for the audience, I'm just going to focus our discussion around three key things for both Jeanette and for Liz. The first one really being about what have your organisations and collectively been doing already in this space, and some impact on that. The second is around what's in the pipeline, and both of you have talked to MASS and some of the other things that you're doing. And the final thing, or the final area of interest, I think, is what does the future hold, particularly with respects to the global landscape, and what are you thinking around that? And I'm just giving you that structure largely for the audience so that they can prepare their questions and comments. So let's just kick off on the first one then. Although I'll direct the question to both of you, I know you both know each other really well, so do please chip in and have the conversation. So let's home in a little bit on what you've done already then, please, and happy for either of you to kick off on that one.
I go first, Liz, and then pass over to you. So Neelam, you've already mentioned the evidence standard framework that NICE developed in collaboration with MedCity and other organisations. We have now published an updated version recently, so that was in March of this year. It's not hugely different from the first version. The idea of this framework, if people haven't used it, is that it categorizes digital health technologies into different functions, and therefore different risk levels according to their function. And then you can look at the different evidence requirements for each tier based on the risk associated with that particular digital technology. So in the new version, we've just renamed some of the tiers and made a few other updates. And I can talk about an update that we're now doing for AI later on. So that's one thing that we've done. That covers all digital health technologies. It does include, it does cover fixed algorithms. So if there's an AI technology that has a fixed algorithm that is, for example, only updated in a batch way, it does cover that, although there's not a lot of specifics on AI in there yet. It doesn't cover continuous learning AI. This is a whole new field where we need to do some more work. So that's a very useful resource for developers when they're looking at developing their AI technologies, and for commissioners who are just thinking, what evidence should I be looking for when purchasing these sorts of technologies? We have also at NICE run Digital Health Pilot, we started a few pilots last year on various digital health products. Some of them had to stop because actually there wasn't the right regulatory they hadn't been through the regulations yet, so we had to stop them, or they didn't have enough evidence, which was very interesting learnings that actually, we do need to work earlier with companies to make sure that they have all of that in place before they come to NICE. But we did manage to complete one, which was for a product called Zio, which is an AI technology that senses heart arrhythmias and detects when there might be a pattern that is a little bit worrying or risky, and then flags that to the clinicians. So our committee, we have independent committees who make our decisions, our recommendations, and they did deliberate a lot over the AI nature of the technology. But in the end, they decided that that had been explained and were satisfied that they were comfortable with the AI nature of the technology. And then the issues they had were issues that we see a lot with lots of other med tech products. It was around long-term outcomes. There were no long-term outcomes for this technology. We don't know what happens to patients in the longer term. And also there was lack of data on resource use. So that is, both of those things being collected in the AI award for that particular product. So that was a really good learning for us, really good training for our committees as well. And it was a good test to see whether our methods worked for AI technologies, and we are satisfied that our current methods are fit for purpose. So we're going to start looking at AI technologies and other digital products as business as usual. And now, of course, there's areas of work we still need to work on, but we will be looking at those as business as usual. I mentioned the AI Award. So this is a project run by the Accelerated Access Collaborative along with the NHSX. And that's a fund that are awarding AI technologies some money for evidence generation and scale up in the NHS. So we've been working with the AI Award team, which has been really good. So this has been my team, and we've learned a huge amount through that. And I think it's been a learning experience for everybody, the developers, the AAC team, etc. How working with companies on what are their evidence gaps, what do they actually need to collect data on, and we have to peel it right back to what is their value proposition, what's the intended use of their product, what are they actually trying to do with it, because these digital products can do lots of different things, and sometimes we need to boil it down to one particular intended use and look at the evidence gaps for that. So that's been really great project helping shape the evidence collection within the AI Award, and hopefully we'll see a lot of those technologies come through NICE later on once they've got their full evidence package. And I've mentioned the mass already. There's a lot still to do there, but I feel that this project, we're working in collaboration with other regulators. This is NICE, MHRA, CQC, and of course the HRA, all joining forces to try to make the regulatory and evaluation pathway for AI and data-driven technologies clearer. And actually it's had loads of benefits already, I feel, just putting us in touch, getting us to work more closely together. And one example of that is closer working between NICE and MHRA on evidence requirements for AI technologies. We both had streams of work that were separate to each other, and we're now in touch, and we're thinking we really need to be extremely collaborative in that area, so everyone can understand what are the evidence requirements for the regulatory purposes, and then what are the regulatory requirements for HTA, and how can we make those aligned.
Thank you, Jeanette. So the baton's over to you, Liz. Can you speak from the HRA's perspective on what you've done so far?
Absolutely. So the Health Research Authority obviously occur much further up the sort of pathway, because we're right at the beginning, often when people are conceptualizing their products and thinking about the research that they might do inside health and social care. So what we have done so far is the HRA acknowledged that this was an area that was we were going to increasingly see products in, and increasingly sort of interesting and maybe complex ethically research. So we've established a team and that's the team that I now run. And this team is looking both to work with other organisations through, for example, the Multi-Agency Advice Service, continue our conversations that we've had in the sector around data access and some of the rules around data access. But particularly, we also have our own program of work that's 6 months in. And what we're doing is looking at the HRA's processes, particularly around applications to our confidentiality advisory group, which is how people get access to confidential identifiable patient information without consent. So that's if you're looking for really big data sets and it's going to be impossible to contact all the participants, then you can apply to the CAG for a legal basis to access all of those records. And then you can go to a data provider like NHS Digital, and they can provide access to that data on identifiable data only. And so that's a really important discussion that we have and have been thinking about, because obviously more of these kinds of applications are likely to be seen because those data sets are quite interesting for this community. So we're working with the Confidentiality Advisory Group to streamline their processes and make sure that these kinds of technologies can run smoothly through the CAG. Also, we have medical device processes. These are done in combination with the MHRA, and they are joint processes. And so if people apply for clinical trials involving these kinds of devices, then it'll be a joint process between us and the MHRA. So also making sure that both our connection between ourselves and the MHRA is running really smoothly, and also that these products aren't throwing any cogs in the system, so that we can make sure that, again, these processes run really smoothly for these kinds of technologies. There's nothing in there. So this program is called Streamlining Data-Driven Research. And currently we're up to the user research phase. So I'm going to be a bit cheeky and I'm going to throw a link in the chat. And if anyone would be kind enough to participate in an interview with our user research company about this area, we'd really appreciate it. Particularly, even if you've never had any contact with the HRA, that might almost be ideal, because yeah, we'd love to hear from you and get your input into how we can develop and grow our systems and make sure that they're really streamlined for this community. So that's what we've done so far. We're looking forward to doing more in this area, and particularly working with our colleagues in NICE, MHRA and the CQC, because this it'll be really nice to be able to work together and make this regulatory pathway really clear for people going forward.
Great, thank you for that, Liz. Just moving on then to, you sort of alluded to, both of you, to work that you are sort of planning as next stages, the pipeline. I also heard both of you talk about you know, some of the things that you've started to implement. So in context of your planning, it would be really useful, I think, to also learn about what impact you've seen from some of the initiatives. So Jeanette, for example, the NICE framework, they've just been updated just to correlate with the medical device sort of tiering. Have you measured the impact of use of the existing framework? Particularly, I know that there were challenges around how commissioners perhaps took up on the framework. You know, have you found any sort of impact on that area? I think that'd be really useful to hear about as you talk about the pipeline. And also, Liz, you know, non-identifiable data and access to that, I mean, that's huge, isn't it? So it'd be really useful if you could also talk through maybe an example and how that's leading you to you know, simplifying and streamlining the process for companies particularly. Over to you again. I don't know if it's Jeanette first and then Liz.
Yes, happy to go, Neelam. So on how the evidence standards framework is impacting on different stakeholders, obviously we took feedback on the first version of the evidence standards framework into account when updating it. And one of the key pieces of feedback we got from users, including on the commissioner side, is that we had originally called the evidence tiers tier 1, tier 2 and tier 3 A and B, and that was really confusing because the medical device classifications are also numbered, you know, class 1, class 2A, class 2B, etc. So that was a point that it was confusing. So we renamed them to A, B and C to make it a bit more useful. We as far as I know, we haven't done any more impact work or sought any structured feedback on the updated version that was published this year. But as we are developing our new version for AI, that will be where we will also seek feedback on where the current version in this particular area, because we're talking about AI, doesn't provide the information that's needed for AI products, both from the developer and the commissioner side of things. It doesn't cover everything that we know people are interested in, and we're interested in NNICE. So that's the impact of that. And then another example of impact is, I talk about the AI award, because I think that's really where we've seen a lot of impact of our work. We did some gap analyses, and in every single case, the gaps that we have identified were then incorporated into the clinical development plans for these AI products. And some of the companies have actually completely, they applied for the award thinking they were going to go in one direction, and actually some of them have completely steered into a different direction, either a different kind of site use case, or had to rethink their evidence plans because they realized that they needed to collect some more baseline data or comparative evidence, for example.
Liz.
Thanks. So I think for us, in terms of data access and thinking about the changes that we're doing through our program, one of the things that we've become really aware of is that not everyone who is maybe doing research inside health and social care is coming to us. So that's one thing to think about. If you're creating a product that will change the kind of treatment somebody will receive as part of their healthcare plan, then it becomes research. It's not just a service evaluation. It's not because health is so important to people, and our role is to make sure that the kind of research that happens inside the NHS that is using NHS resources is of value and has the patient good at heart. We capture those applications. So yeah, if you're making a product that will change the kind of treatment people have, then make sure that when you first start out and are thinking about it, you come to us and get research approval for that. So I think that's really important. And one of the things we've realized is not everyone knows about us. So we're trying to reach out to more communities, including thinking about whether we need to go and talk to students at universities outside sort of traditional health courses to introduce them to the idea that this is part of the way you do research in this space. So those are some of the changes that we're identifying as we chat through the user research. We're also identifying some challenges that people have around data access. So the Confidentiality Advisory Group deals with confidential identifiable patient information. So it's a very particular kind of information, and that's because when people share their data with their healthcare professional, it's in confidential circumstances, so it's covered by the duty of confidentiality. And in order to put that aside under the law, you've got to ask somebody else to put it aside for you. And so the CAG can do that. And one of the things I'll think about and ask about when you want to access that big data set is, have you talked to patients? What kind of patient and public involvement have you done? And what's the public interest? What's the public good that's going to come from it? And that's because those are the criteria by which CAG have been given powers to do this. So, it's really important to think about those questions when you're applying for these kinds of data sets. And the other thing is, I think with our partners across the spectrum, we're starting to think about ways we can empower this community by offering different products. So, for example, MHRA, who Jeanette and I work with quite closely, have developed a synthetic data set around COVID. And so those kinds of synthetic data sets, I understand, are really useful to this community because you can go in and doodle about and try and see if things work early on. There's also A&E synthetic data set and a cancer synthetic data set. So I'm just going to dump the links to those in the chat because I think they're things that people might be interested in accessing. So I think that's also a really important consideration, and one of the things that we're thinking about in terms of planning our work is, can we, because it's about the risk of doing this kind of research, and so can we make sure that our review is proportionate? So we're looking at different ways to make sure that there are ways that this community can continue to grow and develop their products, in the very low risk stage at the start, and when they start to work with, more extensive patient data sets. So, trying to balance that up across the piece. So that's the other thing we're thinking about very closely in this space.
Thanks, Liz. I just had a question. So both of you have been talking about the multi-agency advice service, and I think it's still developing, isn't it? It's still sort of evolving, but and this may be a difficult question to answer, but for those people in industry in the audience, what, you know, if they approached the multi-agency advice service, firstly, how would they do that? Secondly, what would they expect to receive, knowing all of what you've already talked about that your individual organisations are doing? And thirdly, is it free? So those three things.
It is very much in development, Neil, and we're just entering our alpha stage, which means where we've done all our user research, we understand the user needs, and now we're prototyping and testing out different solutions, and also think about what service we can actually offer as 4 different agencies who work in different ways, have different legal remits and ways of working. Well, we think we have a good idea of where it's going. So what people can expect from it, there will almost certainly be some sort of information platform, one place to go to where people can look and find information on the roles of the regulators, who we are, what the pathway is, what the legislation is they have to meet, what the best practice guidance is at different points in the development pathway, and then how to engage with the different regulators. What we don't know yet is whether we will offer like a bespoke advice service. There probably will be an element of that we'll test, whether companies can access all of us together, or whether we'll just signpost to our existing routes for companies to engage with us. We're testing those things out at the moment, and I'll try and find a link and pop it into the chat in a minute on how people can register their interest on the MAS. Because we are looking for companies developing AI to test, do some of this user research on. And then your last question was how much it costs. Well, certainly in this development piloting phase, it will be free, of course, to interact with this. Going forwards, it depends on our future funding model. If I'm completely honest, we're working on it, aren't we, Liz? See how we can make it sustainable and accessible for as many people as possible.
Great, thank you for your openness on that. And it, I can't emphasize enough to engage and interact with the agencies as part of development ultimately benefits industry. So I'm all for early involvement in design. I just then want to move on to the last sort of question to you both before we open it up to Henry and moderating the questions coming from chat. And this is more about the future, I guess. I mean, there is a lot of activities being done here in the UK. You're involved in horizon scanning and knowing how technology is sort of evolving. What do you think, where do you think the future is going to lie? All of what you've talked about, is it future proofed now? Do you think that there is more that needs to be done? And secondly, how do we stack up against the competition? Because industries won't necessarily be interested in just the UK market and access. So lots of questions there, but I'll leave you to unpack them if that's okay. Over to you as to who wants to go first.
I'm happy to start out. I think Jeanette will have some really useful things to say about sort of a more international context. I think from where we sit in sort of the research setting, we're really interested in attracting the best research, to work with some of the best researchers in the world that are based here in the UK, and that includes inside industry. As part of that, we want to make sure that the data store that we have here in the UK, which is sort of a world-class connected data store, and we can see that there are ambitions to continue connecting that data store with more data sets to make it even more granular and interesting. And I think one of the biggest challenges that we see that we face is around trust, public trust and transparency. And so I think where we are going with this, and where I'd make a plea to this audience is, can you help us with that? help us in the ways that we maintain trust from the public and the uses of data, and also be really transparent about when you're working with the NHS and using data, because if we can maintain that trust and that people believe and can see products that really benefit them or their neighbours or people they know, or communities they have contact with, we'll be able to continue to drive development in this area. But I think, yeah, there's some question marks that people have raised about some of the arrangements between companies and NHS data stores, and so we're trying to work through that, and we have some guidance that we'll be producing on data-driven technologies and that kind of interrelationship with the data holders, because we know that this is a really important space and we want to help everyone maintain that trust and work in a really collaborative way.
And I was also going to mention collaboration, so it's a good point to take off, as Liz talked about working in a collaborative way. I think we're finding in the digital and AI space, collaboration is absolutely key because it's such a fast moving field. Each organisation can't work on their own. Now that MHRA is our sovereign regulator, now we've left the EU, it's great to be able to work with them more closely as well. And I think both NICE and HRA are finding that relationship really useful and fruitful and collaborative. So to answer your question, Ian, are we there yet? No, I think we've got a system that where there aren't gaps in the regulatory process. We've done that mapping, and it is suitable for AI technologies. But is it future-proof? Probably not. So we're working collaboratively to make it much more future-proof. MHRA are updating their regulatory framework for AI and software as a medical device, which we're all inputting on at the relevant points. And at NICE, we're developing our evidence standards framework specifically to look at AI. And in the MAS, where we're working as 4 collaborative partners, we've identified some key policy areas where we all need to work on together. And these are, well, one is evidence requirements, and another one is, I saw a question in the chat that's popped up around algorithm updating and what is required from the regulatory system when an algorithm updates. And the other one is on continuous learning algorithms, where we haven't yet set what the evidence requirements are for those. We've done obviously some thinking and some talking to experts and academics around this area. There's a lot more work we need to do to actually define that so that it's really clear to us as decision makers and to developers what is going to be needed for these algorithms that just continuously learn and update, and we're letting them free into the NHS to do that using patients in the NHS. So yeah, there's more work to do. In terms of the international side of things, we are working in this area in digital health and AI with many of the other HTA, health technology assessment bodies. So we've just started a collaboration between CADITH and Canada, the MSAC committee in Australia, and our partners in the devolved nations as well in the UK, to sit down and work through some of these things together so that we're not saying different things and making it confusing for developers, so that we can try and align what our evidence requirements are in that area. And I know the MHRA have been looking closely at what the EU have done, and are engaging with the FDA as well. So there's lots of learnings I think we can take, but I don't think anyone's really there yet in the international space, and no one's cracked it, I don't think, in terms of the whole regulatory and evaluation pathway from research to deployment. So I think it's more about collaboration and working together rather than copying what others have done.
Yeah, I totally agree with you. I don't think anyone is there yet, and in some respects, because it is a fast-moving space, I guess the question is there an end point at all, or is this a sort of continuous learning journey? And that's, that I think more to come, I'm sure, on that. So with that, I want to just thank you for bearing with me and my questions, and it's over now to Henry to open up questions from our audience. Henry.
Hello, everyone. Lots of exciting questions coming into the chat. I'll try and pick some out and merge together different questions. There was a great question early on, so let's throw you in a deep end with this one. So the NICE evidence standards framework, for each of those tiers, it sort of gives a minimum you have to do, and then it sort of gives a gold standard. How are companies meant to decide what they should do between those two bounds? Is there any support for them there?
Yeah, we've been talking to quite a few companies about this, and there's some guiding points in the evidence standards framework on when companies should look at following the best. I mean, all companies should try and follow the best practice standards anyway, but when they should definitely be looking at following the best practice evidence requirements. And AI and machine learning is one of those areas where, because of the more black box nature of the technology and the uncertainty of how it might act in and perform in the real world, we steer companies towards the best practice standards for them. But saying that, we've worked with a lot of companies, but more recently, where these AI tools, they're often not being deployed at the moment anyway in the NHS to completely replace a decision that a clinician is making. They're often being deployed as decision aids, as something to help diagnosis, for example, or help triage a patient. But then there's always that backup check, or the final decision is made by an actual healthcare professional, by a human still. So there the risks are not as great, obviously, as if you're just deploying the AI and it's completely replacing the decision of a human. And so there's definitely each case is slightly different, and if the risk is actually lower of deploying an AI technology, because it's a decision aid rather than replacing a decision, then pragmatism has to be taken into account, and maybe the best practice standards are not necessary, and the standard ones are fine. So in terms of the support for that, companies can engage with scientific advice at NICE. We've got the Meta tool, which is an online gap analysis tool, which is where we also take companies through the evidence standards framework and help them think through where they might sit as well. So there is that on offer, and often it's not NICE deciding you are definitely in this category. It is about getting the company to think about what the risks are behind their technology and where they're going in the future as well, because a lot of companies are thinking, oh, I currently sit in this tier, maybe tier 2, tier B, but then when you talk to them and they're talking about their future development, actually that's changing the clinical pathway. It's having patient outcomes. Patients, if it didn't perform right, actually patients could suffer. So actually you're in the future, you may well be designing something that's actually a higher evidence tier. So I think it's about having those conversations to tease these things out.
Thanks, Jeanette. Lots of comments in the chat, and we'll send the chat round to our speakers afterwards as well. You've talked a bit about this challenge of regulation for continuously updated AI models or even occasionally updated AI models. There's also a question around the FDA's proposed regulatory framework in the US. Have you seen that? Is that, do you think, a good model, a bad model?
The MHRA would be better placed, I think, to answer that question rather than us, as obviously the FDA are looking at the kind of regulation and licensing of these devices, and I know MHRA are looking closely at what the FDA has done. And but yeah, no, but nice. We're looking at it as well, and seeing whether that would be useful. We also looked at Australia have just produced guidance in this area from a health technology assessment perspective around how we can continue at the point of evaluation. When you say, should we pay for this AI technology? How can we have confidence at that point that the continuously updating algorithm is going to continuously update in a effective way that maintains cost effectiveness as well, and how can we think about the monitoring requirements for that, and that's why linking up with the regulator is important, because the regulator, MHRA, will have monitoring requirements, and NICE would also have we might not be able to enforce it, of course, but we probably would come back and review our guidance according, more regularly than we do now. And that's one thing we need to prepare for and future-proof ourselves, is by expanding our capacity to be able to review our guidance when these algorithms update in the future.
A question for both of you. We have seen huge changes over the pandemic, obviously in all aspects of life, but very much so in digital health. But a lot of what we've seen hasn't been around AI, it's been around other aspects of digital health, like telehealth. What's the offer going to be there? Is there an equivalent to MAS?
This is something we've been discussing at NICE, because traditionally at NICE we would evaluate technologies that are on the more complex end, that have higher costs associated with implementing them and have higher risks or potential benefits, of course, for patients, so things that have real patient outcomes. And so we are currently focusing on Tier C in the evidence standards framework technologies that wouldn't include telehealth technologies, but we have been discussing whether there is a need for this kind of value assessment of those sorts of technologies. Certainly, obviously at the local level, they are doing local health technology assessment. Is it going to save on costs? Is it going to impact on patient outcomes, etc.? So is there more we can do to support local level decision making as well? In terms of, is there an equivalent to the MAS? Well, not yet. Let's get the MAS up and running first. But certainly the MAS is not, we realize from our user research, it's not just for AI products, it's also for data-driven products, things that are using data sets to calculate outcomes that could impact on patients, for example. So we've already expanded it beyond AI, because it's quite hard to define sometimes what is AI and what's not AI, but also because the challenges are very, very similar for a large set of digital health technologies. It's not just those that have traditional machine learning in it, for example. Is there anything else you wanted to add?
I was just going to say that it's not probably digital health generally, but there is going to be some increasing use of digital products in this establishing clinical trials. So I'm working on another project that's under the Resilience, Recovery and Growth portfolio that is looking at how we can use data-driven approaches to help with the establishment of clinical trials. Because I know we've seen during the pandemic an increased remote monitoring and remote setup of clinical trials. So I think, yeah, it's not a single point on digital health, but there will be increasing guidance and services available to use digital technologies in order to do things like clinical trials.
Thanks, Bo. It may just be me, but I've always felt that there's a lot in Tier A that has huge potential to affect patient outcomes, but because it's considered administrative in some sense, it seems to just get ignored, as if the multi-million-pound budgets being spent on it don't require evaluation in the same way. And obviously there are other evaluation activities going on, but yeah,
Interesting on that point, Henry, we've actually come across quite a lot of companies who don't want to be in the higher evidence tiers, because obviously that means more money they have to spend on research. So actually companies are trying to be in tier A if they can be, even though actually when we look at them, and a lot of triage technologies and lots of AI are doing this kind of triaging, that is really where they're saying they're an efficiency tool, they're saying they're an administrative tool, that's how they're selling them. But actually when you look at them, they are making decisions around how critical patients are, when they should be seen, where they should be seen, etc. And those could have quite, as you say, quite important health impacts, and probably should be higher up in the tiers. So there's a bit of yeah, there's a lot of technologies sitting in those lower tiers that actually might not maybe they shouldn't be there, and we should be looking at them because actually they have much higher impacts than we think.
That's a really interesting point, and perhaps also applies to the Health Research Authority, where, I mean, the very sensible strategy for many a company is faced with these grey areas. Are you tier A? Are you tier B? Are you service evaluation? Are you research? Where there aren't clear definitions, the sensible thing in practice for a company to do is to go, oh, okay, I'll call this service valuation, or I'll call this tier A. Is that a worry? Is that something you will seek to police more in the future? Is that what do you think? What do you think is going on in these areas?
Yeah, and we certainly see that people want to call something a service evaluation and avoid having to apply for ethical review and legal approvals for the work. What I would say to that is, what I've also seen is people developing a lot of products without the sufficient input to make sure that they are usable at the other end, so that they actually fit into the NHS system. So if you do the research properly at the beginning and involve patients and come through the process, then we can actually help you improve your product and your research by giving you access to all the expertise on our committees and all the people that we have contact with, so that you have addressed some of those things and have thought about some of those answers, because it's really important that whatever is produced, both patients and clinicians and healthcare professionals can interact with, and it fits with the system that they work inside, which is very complex. And so I think interacting with the regulators early on and is actually can be a really beneficial part of the process, and we are really open to trying to make that easier for everyone, because we think at some point, and I know this is probably a lofty ambition, we want people to want to come to us and interact with us about their work, because we do add value to the process. So yeah, that would be my dream and my goal. But yeah, I think it's really important that people don't just try and skirt around the regulation, because it's there for a reason.
I just remind people that there's been a couple of links put in the chat. If you want to take part in some sort of user research for these forthcoming ideas, or if you just want to take part in the multi-agency advisory service, there's a form now in the chat that you can fill in your details. I think we've got time for a few more questions though. So do you have a sense that, this is for Jeanette, although perhaps there's some broader issues for Liz as well, the evidence standards framework has worked in terms of speeding up commissioning decisions?
That is a tricky question, Henry. We haven't got any data on it. It's a very difficult thing, obviously, to measure. So it's just anecdotal, but it has certainly been useful to have that framework that applies not just to a niche part of the digital health technologies, that it applies that all digital health technologies should be fitted in there somewhere. And in fact, it's been so the feedback has been so positive that thinking, should we do this for all medical technologies and not just for digital, even though that's where we started. So yes, I think feedback is positive. I don't know about speed. It's always something that we deliberate on. Obviously, we do want to pull through the best technologies as quickly as we can. We want to make sure that technologies that we talked about before, they're trying to skirt the regulations, though, don't quickly get to market, but they do follow the regulations and the evidence, and collect the evidence they need to before they can enter the NHS.
So the framework is still, though, advisory. It is not actually a regulation. Has it become a de facto regulation? Is it something you think that commissioners expect, or is your sense that things are still in flux?
I think it's still in flux. They are best practice. It's best practice guidance. We don't enforce it, obviously, and we need to work with commissioners to work out how they're using it. And I certainly couldn't say it's been used across the whole NHS. When we're thinking about, a slightly different tangent, when we're thinking about the mass, we're also thinking about how we can measure impact of it, and we've got an evaluation partner that we've brought in, sort of independent partner to help us work out how we can measure the impact of it, looking at baseline data. They're doing surveys of developers and adopters around how do they find the regulatory and evaluation pathway right now, and then looking at the impact, or setting up a framework at least that we can use hopefully in the future when we launch the mass, to see whether we have had an impact. And I think that's really useful, because we didn't really, it's not something we had the resources to do for the evidence standards framework, if I'm completely honest with you. But hopefully we can do that with the mass and actually demonstrate the value that approach of joining up together, making the regulatory and evaluation pathway clear, having that clear route to how to engage with all of us regulators, and how we can actually measure the benefits that's had for the whole system.
Maybe we only have time for one or two more questions. There's a really interesting question, perhaps more for Liz, asking around where is the value? Does the value come from the data that one can get through the NHS, or does the value come from the innovators and what we're doing with it? And there's been a lot of questions and issues around sort of ownership of the data, access to the data. We've got the Bengal data review ongoing. I understand there was a almost finished draft, so that should be coming out soon. This, though, also has sort of implications for who pays for things. So the NHS, in some sense, and all of us as patients, is providing value in terms of our data. Companies are developing innovation, they are innovating, and so they're providing value in some sense. But if I can summarize that in another way, who therefore should pay for the evaluations at the end of all this? Should companies be paying for their own evaluations? Is that a cost we think companies should cover? Should the public sector, the NHS, be paying for evaluations because it's helping us determine what the NHS should pay money for? Is there an issue around the independence of evaluations? If a company's doing its own evaluation, does that raise issues? Yeah, sorry, that was about 6 questions. Liz, go on, answer all of them.
Yeah, that's a really important question about value, and I'm sure if Jeanette can add to this, because evaluation is much more strongly connected to her work. But I think it's a combination of two things. So depends where you sit in the system about what kind of value you see. So if you're a patient sitting in the system, sometimes the value that they're hoping to generate by connecting up all of the digital systems in the NHS is you don't have to tell every single healthcare provider you come across the same data over and over again. And that if you touch the healthcare service, your history is there, so that you know that they know everything about you, so they can treat you appropriately because they've got your history. And so some of the integrations that we're seeing around digital is to improve those kinds of experiences. So the value for the patient then is an improved healthcare service. In terms of the value of the data source, the sort of secondary use of that data, yes, there's massive value in that data store. But I think the trade-off is, and this is really what we're seeing from a lot of the public and patient involvement, is they're happy for that data to be used, but they want to see that for public benefit, because it is a massive public good, right? It's a thing that we all own and contribute to. So yeah, that comes back to that point. So the National Data Guardian has done some work around, you know, what is public benefit, trying to standardize some of the terminology and the way we assess that. They've got a report out called Getting to Good that, you know, summarizes all of the public engagement work they did on this point. And the public have say that they're very happy for their data to be used, provided they can see the public benefit. So I think that's the trade-off in terms of the use of the data, that, you know, companies get to use it, but they have to, you know, improve things for a group of people or a lot of people. So I think that's really important. As to who pays for the evaluation, I think we're still really working through that. And a lot of the work that we've done with NHSX is around, well, how do you create the right kinds of tools, like validation tools, bias tools, those kinds of things, so that it's not cumbersome to be able to do that evaluation process appropriately, and there's some sort of sense that these are things that multiple players in the market can rely on. But I think we're still really working our way through that to figure out how that works in a really effective manner. I'm sure you've got things to add.
Yes, I think your points around thinking about the patient and the patient needs are absolutely critical, particularly when you also add in the question of who should pay for it. So if there is a really critical unmet need in the NHS and patients really need a particular new device that could you know, massively help help them and help a huge issue in the NHS, then there's more argument that maybe it should be the public system that does support that real world evaluation, that you know, deployment and further evidence collection to test out whether something is valuable for the NHS. If there's not such a patient an unmet need, there's less of an argument that it should be the NHS paying for that, or the public system paying for that. Companies should to look at paying for that themselves. I think, you know, we can't ask the public system to pay for everything, because that the companies will reap all the benefits monetary wise. Obviously there will be some benefit for patients, but we will probably spend far more than we get in terms of patient benefit.
Back to you, Neelam.
Thank you very much. So we are coming up to time, and I just wanted to thank you very much, Jeanette and Liz, for contributing to this session, and it feels like we've emptied your brain, so hopefully it was enjoyable for you to be quizzed in the manner that you have been quizzed. Very quickly, some takeaways from me. I think we heard about the evidence framework, the work that's been done to update it, and also some of the plans around the future of it. We've heard about the CAG and the service that the HRA have put in terms of accessing non-identifiable data and some of the work that's involved in that. And we've also heard about the MAS, and which is a great next step forward. So in the chat we've had lots of questions of which we'll take note, and hopefully we've answered many of them, but if not, we certainly will be taking them down and answering them individually if we can do. I'd like to encourage the audience to just listen back to previous webinars, and here's the link for previous webinars. Finally, we started off this session asking, regulation, evaluation of AI, are we there yet? I think the conclusion is that this is a journey, possibly there isn't an end point, but everyone on this webinar should feel part of that journey, and it's brilliant that you all have been involved and been so interactive. So thank you very much also to Henry and to the team behind the scenes at DHL who've been fronting the slides and making this all happen. So with that, have a great rest of the afternoon, and hope to see you again in another series.